examination of cardiovascular outcomes with Alogliptin versus standard of care in patients with type 2 diabetes mellitus and acute coronary syndrome.
Thank you, Dr. Harold and Dr. Bademan. It's a pleasure to be here in Amsterdam this morning at this press conference. I'm going to be presenting the objectives and endpoints of XAMINE, which was one of the recent studies ruling out cardiovascular risk in a population of high-risk patients with type 2 diabetes mellitus with one of the new drugs for the treatment of diabetes, Alogliptin, a DPP-4 inhibitor. The primary objective of XAMINE was to demonstrate that major cardiovascular events are not higher with the drug compared to placebo in type 2 patients with a recent acute coronary syndrome who are also receiving the standard of care for diabetes as well as for secondary cardiovascular prevention around the globe. The primary endpoint of the study was the composite of the first occurrence of cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke. If non-inferiority had been achieved at the time of the appropriate evaluation, then superiority assessment would occur in a hierarchy of statistical analysis that would attempt to evaluate whether or not we demonstrated a reduction in cardiovascular events on Alogliptin versus placebo. A pre-specified secondary endpoint was the primary endpoint, including an additional component which was urgent revascularization due to unstable angina. And then major endpoints that were also evaluated were cardiovascular death, that included those that were part of the primary endpoint and those occurring subsequent to a non-fatal primary endpoint, and all-cause mortality. So I went out of order. The patients in the study were those with type 2 diabetes receiving antihyperglycemic therapy, either alone or in combination with other drugs. They had to have had an acute coronary syndrome within 15 to 90 days of randomization, and that was defined as an acute myocardial infarction or hospitalization for unstable angina with very strict criteria. They also received local standard of care for type 2 diabetes and secondary prevention with the exclusion of other DPP-4 inhibitors or GLP-1 agonists, since they would have confounding mechanism of action. Patients with unstable cardiovascular conditions or those on dialysis within 14 days of planned randomization were also excluded from the trial. This is the sort of a snapshot of the primary finding of this trial. A non-inferiority was met for all the endpoints. If you look at the figure at the bottom here, 1.3 is the mark of non-inferiority as defined by this trial as well as by our regulatory agency, the Food and Drug Administration, that the upper bound had to be less than that. And for the primary endpoint, it surely met that with a point estimate of 0.96 and an upper bound of 1.16, with 621 major adverse cardiovascular events in the trial. The secondary endpoint, likewise, with the inclusion of urgent revascularization for unstable angina, had a point estimate of 0.95 with an upper bound of 1.14. All cardiovascular deaths now are being shown as a 95% confidence interval. All cardiovascular deaths had a point estimate of 0.85 with an upper bounds of 1.10, and all-cause mortality 0.88 with an upper bound of 1.08. To summarize all major findings from this trial, the rates of major cardiovascular events were similar with Alogliptin compared to placebo in patients with type 2 diabetes and recent acute coronary syndrome. This observation occurred in the following context: significantly lower hemoglobin A1C levels, also known as glycated hemoglobin, of 0.36%, and that was persistent during the course of the study, median duration 18 months, but up to 40 months of treatment. A high overall cardiovascular event rate of 11% for the primary endpoint with a median follow-up of 18 months, and a high level of standard of care for both diabetes and for secondary cardiovascular prevention. Outcomes were similar for the secondary endpoint that was just mentioned, and the rates of cardiovascular and all-cause mortality were similar in the Alogliptin and placebo groups. There are also similar rates of withdrawal due to adverse events in both treatment groups at about 10%. And other adverse events of interest for this particular class of drugs Whereas follows, there were no differences between alogliptin and placebo in the incidence of hypoglycemia, including severe hypoglycemia, no difference in reported malignancies, and there were no cases of pancreatic cancer. There were no differences in renal function, including the initiation of dialysis, and there were low and similar frequencies of acute and chronic pancreatitis in each treatment group. So our conclusion of the study is that in patients with type 2 diabetes and recent acute coronary syndrome, major adverse cardiovascular events for the DPP-4 inhibitor alogliptin were not increased compared with placebo. Thank you.
Thank you very much. So you can pose your questions now for Dr. White. Yeah, please.
Dr. White, I'm going to jump ahead to the SABRE trial and ask about the heart failure finding in that and what you think it means for the class of DPP-4 inhibitors.
Well, first of all, I appreciate the question, but I would not think it'd be fair to the SABRE speaker for me to jump ahead and ask questions about his trial, so perhaps it's better if he answers that question. He's speaking right after me.
I understand, but I'm asking you about it for other DPP-4s.
Well, all I can tell you is that in this particular study, in XAMINE, heart failure was not increased on alogliptin relative to placebo for hospitalization for heart failure. However, we have not completely finished our analysis of all the secondary cardiovascular endpoints because we just locked the database about 5 weeks ago. So there are many other aspects of this trial that are not in today's presentation.
There's a question back there. Oh, yeah.
Larry Euston, Cardio Brief. Is there a compelling reason to take this drug?
Well, the way I look at it from my colleagues in diabetology is that, right now the first-line therapy worldwide is metformin. What should be the second drug is sort of up in the air. People use sulfonylureals. They have some concerns. You can use insulin. You can use TZDs. I think when you have data such as this supporting a lack of a safety signal in a very high-risk population, it gives enhanced credibility to the use of a DPP-4 inhibitor as a second drug in addition to metformin, which, by the way, I didn't mention this, but 2/3 of our patients were on metformin in the trial, and it was balanced between the treatment groups. But I think that would be compelling, yes.
Just to push back a little bit, to say it doesn't kill you is not exactly a good reason to take it, right?
Well, it lowers glycemic indexes significantly, and as we know, in treatment of type 2 diabetes as well as in type 1 diabetes, if you are lowering A1C levels, you are lowering microvascular event rates such as retinopathy and nephropathy. So I think that there is that benefit. Now, we don't have benefit in these shorter-term trials, but we know from the prior literature that it might take 5 years plus before we'll determine a down-the-stream macrovascular benefit of lowering blood sugars over a sustained period of time, and with a drug which doesn't enhance cardiovascular risk.
Okay, if there are no further questions, we'll move on.